the symptoms of ICU delirium. It has no significant effect on respiratory drive or hemodynamic function in euvolemic patients, but its onset of activity may be delayed for 15 to 20 minutes. Many dosing protocols exist, including multiple small intermittent doses, rapidly escalating doses, and the administration of continuous infusions. It's unclear which strategy is optimal, but recent data citing the relationship between haloperidol doses greater than 35 milligrams daily and torsades de pointes suggest a conservative approach. The odds of developing this ventricular dysrhythmia are highest when the QT interval exceeds 521 milliseconds. This highlights the potential risk for concurrent therapy with other agents affecting repolarization, such as amiodarone, azole antifungals, fluoroquinolones, and macrolides. It's prudent to ensure adequate potassium, magnesium, and electrocardiographic monitoring for haloperidol-treated patients, and perhaps avoidance of this agent altogether in patients with a history of heart disease. To avoid some of the prolonged QT syndrome and movement disorder issues associated with haloperidol, many clinicians have adopted the use of second-generation antipsychotics, despite very limited data supporting this practice. Second-generation antipsychotics share many of the side effects of haloperidol, including neuroleptic malignant syndrome. They have agent-specific adverse event profiles as well: hyperglycemia, bradycardia, pancreatitis, and hypotension with olanzapine, prolongation of the QT interval with ziprasidone, agranulocytosis with clozapine, and sedation with quetiapine. Although elderly patients with dementia have a greater risk for cardiovascular infectious sequelae when treated with a second-generation antipsychotic, it is unclear if this risk extends to the short-term treatment in similar patients with ICU delirium. Neuromuscular blocking agents should never be used alone. It is often more important to have an induction hypnotic agent that is short-acting to facilitate intubation. Only if it appears as though intubation will likely be successful should a neuromuscular blocker be considered. And even in that case, it should always be short-acting. The ultimate endpoint is to keep the duration of time between cessation of breathing and eventual definitive airway as short as possible. Since it is often unclear when a patient is in discomfort, agitated, or simply in some physiologic distress, concurrent sedation, even with a definitive airway, is paramount to prevent traumatic disorders after a period of paralysis. Recall of an inability to move is much more disturbing than recall of pain, yet minimizing both is advantageous. Given the multiple reasons for which sedation may be required in the ICU, every effort should be exercised to achieve comfort before neuromuscular blockers are utilized. This is particularly important the longer a patient is in the unit due to increasing tolerance. Once initiated, neuromuscular blockers should be minimized as much as possible because duration correlates with the development of intermediate duration of weakness. Probably the most likely use for neuromuscular blockers is to facilitate mechanical ventilation in patients with dysynchrony. However, there are many other possibilities in which the complete relaxation achieved is one level more than can be reached with sedation alone. There are two classes of neuromuscular blocking agents, depolarizers and non-depolarizers. Succinylcholine has been around a long time and as the only drug considered a depolarizer because it has qualities that are unique from any other drug. There are several non-depolarizers that may be popular for particular situations. For example, atracurium may be helpful in a patient who has renal or hepatic failure due to its breakdown by serum esterases. Pancuronium may be particularly helpful for more consistent paralysis. In patients where aspiration is a real proximal concern, there are really only two drugs to consider. Both succinylcholine and rocuronium have a very fast onset of action to produce intubating conditions as quickly as possible. The goal would be to minimize the time between a fully oxygenated, spontaneously breathing patient and successful intubation. The advantage of succinylcholine is the short duration of action. When doing a rapid sequence, neuromuscular blockers are essentially part of the induction without question. If a definitive airway is not achieved, there is the potential that the patient could be allowed to wake up and a different route could be tried in a setting of an unknown difficult intubation. Succinylcholine is still used frequently for specific situations that take advantage of its benefits. However, there are many side effects from minor issues related to myalgias to the more major concern of hyperkalemia. The non-depolarizers are still relatively quick, although not quite so much as succinylcholine or rocuronium. Single doses are often determined based on the duration of action as well as the route of elimination. Here are some examples of infusion ranges used clinically for ICU patients. Pancuronium has a longer duration of action but also stimulates the sympathetic nervous system, producing tachycardia. Continuous infusions with medications affected by organ dysfunction can cause accumulation of the drug and its metabolites. The methods described on this slide are designed to minimize the use of neuromuscular blockers as much as possible, which will decrease the potential of developing side effects after cessation. Limiting the degree of relaxation is just as important as keeping the duration as short as possible. There are no clinically proven monitors of sedation or amnestic level. Therefore, it is very important to follow trends in medication administration. For instance, if a patient has been on the same amount of midazolam infusion for a week, an increase may be required secondary to tolerance. Since the patient is heavily sedated or paralyzed, it may be difficult to assess distress from discomfort or awareness. Vigilance is required for any duration of paralysis. Patients must have regular physical therapy. Protocols needed to assure that patients do not stay in one position for too long, which increases the risk of ulcers, must be in place. To avoid corneal damage from exposure, an aqueous eye ointment will be helpful. Daily cessation of paralysis is important not only to minimize duration, but also to allow a short period of patient assessment.